Usually, when we talk about a medical diagnosis, there's this expectation of precision, you know?
Right, yeah, like it's a math equation or something.
Exactly. It feels like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, there it is, that's the problem, and here's exactly how we fix it.
It's very binary. Broken or not broken, you put a cast on it and, well, you go home. We like things to be neatly categorized so we can just formulate a direct plan of attack.
But what happens when the organ you're looking at suddenly starts, like, digesting your own body from the inside out?
Yeah, that's when the engineering analogy completely falls apart.
It really does.
Yeah.
So today we are wading into the terrifying, murky waters of acute pancreatitis. If you're listening to this, you're someone who wants to understand the underlying mechanics of the world. You want to know how things actually work without, slogging through a dense medical textbook.
Which is completely understandable. Medical textbooks can be a bit dry.
Just a little bit. And today our mission for this deep dive is to extract the logic behind how medical professionals battle a really complex, cascading bodily crisis.
And it truly is a masterclass in chaos. I mean, acute pancreatitis is not just a disease of the pancreas. What makes this topic so compelling and, frankly, so terrifying when you're actually standing at the foot of the patient's bed is that it's this massive, unpredictable, body-wide alarm system.
Okay, wait, before we get into the whole body, just where is the pancreas and what is it supposed to be doing normally?
Good question. So the pancreas sits deep in the abdomen, kind of tucked behind the stomach, and it's quietly producing digestive enzymes all day long.
Right.
But when it becomes inflamed, those enzymes can leak, and they essentially begin to digest the surrounding tissues.
Wow.
Yeah, which triggers this huge inflammatory cascade that can shut down organs that are nowhere near the pancreas.
Okay, let's unpack this. The concept of your own enzymes just, like, turning against you is wild. And before we can even look at long-term outcomes or how a patient recovers from something like that, we really have to start at the very first moment a patient enters the hospital.
The emergency room presentation?
Right. They're coming through the ER doors in excruciating, unrelenting abdominal pain. Now, for a very long time, the immediate medical reflex in this specific scenario was to fight fire with a massive flood of water.
It was the absolute standard operating procedure for decades. I mean, acute pancreatitis is an intensely inflammatory condition. And when the body is that inflamed, the blood vessels become leaky.
Leaky, like they actually open up.
Yeah, exactly. Fluid shifts out of the bloodstream and into the surrounding tissues. It's a process we call third spacing.
Third spacing, got it.
Because the fluid is leaving the blood vessels, the patient's blood pressure starts to drop dangerously low.
Which naturally triggers the instinct to fill the tank back up. I mean, if the blood vessels are empty, you need to pump fluid into them to keep the heart pumping and the organs alive, right?
Exactly the logic. The medical community really believed that aggressive fluid resuscitation was the only way to maintain organ perfusion.
Just keep the blood flowing.
Right, and essentially flush this massive inflammatory fire out of the system. We are talking about hooking up intravenous lines and pushing liters upon liters of fluid into the patient as fast as possible.
But we're currently looking at a massive paradigm shift in how this is handled, driven by a recent highly significant study called the Waterfall Trial.
Yes, a very aptly named trial.
It was published in the New England Journal of Medicine, spanning 18 different hospitals. And they wanted to test this exact reflex, like, are we actually doing the right thing by flooding the system?
So the researchers randomized patients into two distinct treatment tracks to finally get a definitive answer. The first group received the traditional aggressive fluid resuscitation.
And what does aggressive actually look like in an ER?
To give you an idea, it involves an immediate, massive, rapid infusion right up front. If you have an average adult weighing roughly, say, 80 kilograms, the aggressive protocol demanded pushing over 1.5 liters of fluid into their veins almost immediately.
Oh, wow. Just right off the bat.
Right off the bat.
And then, after that initial deluge, they follow it up with a continuous heavy drip every single hour. It's like a fire department responding to a house fire by hooking up the biggest hoses they have and just completely flooding the entire structure.
That's a great way to picture it. Meanwhile, the second group in the trial was placed on a moderate regimen.
Okay.
They only received a rapid infusion, and a much smaller one at that, if they were actively showing clinical signs of severe dehydration or low blood volume.
So if they look somewhat stable, they just didn't get the initial flood.
Exactly. If they were stable, they skipped the rapid push entirely, and their continuous hourly drip was, well, it was cut in half compared to the aggressive group.
So you have one group getting the traditional flood and another group getting a highly conservative trickle. And the trial was measuring whether the patients developed severe acute pancreatitis, but they were also meticulously monitoring a primary safety endpoint, which was fluid overload.
Right, and what's fascinating here is the interim analysis.
The halfway point.
Yeah, the trial was designed to study a massive cohort of patients, but they paused to look at the data after just 249 people had gone through the protocol.
Which isn't a huge number for a giant trial.
It's not. But the results at that early stage were so glaring and so definitive that the Safety Monitoring Board actually stepped in and terminated the trial entirely.
Wait, really? You don't just pack up a massive multi-center international trial early unless you're seeing a glaring red flag. What did they find?
They found a staggeringly high incidence of fluid overload in the aggressive group. Over 20% of the patients receiving the traditional flood of fluids developed fluid overload.
20%.
Yeah, compared to just over 3% in the moderate group.
So giving them the aggressive fluid treatment nearly septupled their risk of fluid overload. And from you listening, fluid overload in this context is not just, feeling a little bloated or having swollen ankles.
Not at all. Remember, the blood vessels in these patients are already incredibly leaky due to the systemic inflammation we talked about.
Right, the third spacing?
Exactly. When you pump liters of fluid into leaky pipes, the fluid doesn't stay in the pipes. It seeps into the surrounding tissues. And most dangerously, it seeps into the lungs.
Oh, man.
The tiny air sacs where oxygen exchange happens become completely waterlogged. The patient essentially begins to drown from the inside out.
That is terrifying.
It makes it incredibly difficult to breathe and puts immense crushing strain on the heart.
And the really tragic part of this data is that taking on all of that risk and suffering that fluid overload didn't actually buy the patient any medical benefit at all.
None. The aggressive fluid resuscitation offered absolutely no improvement in clinical outcomes. Zero. The statistical data proved that this wasn't a coincidence or a fluke. Pumping these patients full of aggressive fluids was actively harming them without doing a single thing to stop the pancreatitis from getting worse or healing the organ.
So if the house is already waterlogged, pumping more water in doesn't put out the fire. It just guarantees the foundation is going to collapse. The water damage becomes worse than the fire damage.
It perfectly captures why these findings are forcing hospitals to completely rewrite their emergency protocols. We are moving away from routine, blanket, aggressive treatments. You can no longer just look at a diagnosis of acute pancreatitis on a chart and blindly turn on the fluid faucet.
Right.
The approach must become incredibly cautious and individualized.
But practically speaking, standing in an emergency room, that sounds like an absolute nightmare for a doctor. If you can't rely on a simple one-size-fits-all protocol, how do you know exactly how much fluid the person in front of you needs? I mean, you're walking this terrifyingly narrow tightrope.
You really are.
Give them too little, and their kidneys die from lack of blood flow. Give them too much, and you drown their lungs.
It is the ultimate critical care balancing act. And this is where we're seeing a fascinating intersection of medicine and technology. Because human calculation has limits, ongoing trials are now utilizing machine learning-based severity prediction models to guide these exact bedside decisions.
Okay, wait. How does an algorithm step into an emergency room to tell a doctor how to treat a pancreas? Like, what is it actually doing?
So a machine learning model can ingest hundreds of physiological data points in real time. It looks at the subtle beat-to-beat variability in the patient's heart rate, their exact age, microscopic shifts in their blood chemistry, their respiratory rate, their temperature, all of it.
That's way more than a human brain can track at once.
Exactly. It takes that highly specific biological fingerprint and compares it against tens of thousands of historical hospital cases in milliseconds.
So instead of a doctor guessing based on a visual assessment, the algorithm says, based on these 50 variables, this specific patient is at an 85% risk of fluid overload in the next 6 hours. Cap their intravenous fluids at this exact milliliter rate.
It removes the guesswork. It provides a highly sophisticated dynamic tool to help clinicians navigate that tightrope safely. And this need for individualized, precise care naturally leads us to the broader, overarching challenge of this disease.
Which is figuring out who's actually in danger.
Right. If we can't apply a blanket treatment, we desperately need to know, the moment they walk through the door, which patients are going to recover smoothly and which ones are about to fall off a cliff.
Which brings us to the art of early risk stratification. Because at first glance, the baseline mortality rate of acute pancreatitis overall seems relatively low. It hovers around, what, 1 to 2%?
Yeah, about 1 to 2%. But that average is incredibly deceptive.
Because it groups everyone together.
Exactly. It masks a terrifying clinical reality. Most patients have a mild case. They require some pain control, intravenous hydration, a few days of fasting to let the pancreas rest, and they go home.
Okay.
But for the percentage of patients whose disease is classified as severe, that mortality figure skyrockets. The difference between a mild and severe case is the difference between a 3-day hospital stay and a multi-month battle in the intensive care unit on a mechanical ventilator.
So early assessment is quite literally a matter of life and death. The medical team has to look at the patient in hour 1 and make a definitive triage decision. Do they go upstairs to a regular medical floor, or do we bypass everything and rush them straight to the ICU?
And historically, the medical community relied on incredibly dense, complex scoring systems to make that call. The most famous ones were the Ransom criteria and the Apache 2 score.
Apache 2. I mean, that sounds like a piece of military hardware. What exactly is it measuring?
It is basically a massive physiological calculator. It measures everything: age, core temperature, mean arterial blood pressure, heart rate, respiratory rate, arterial oxygen levels, blood pH, serum sodium, potassium, creatinine for kidney function, hematocrit, white blood cell counted, and even a neurological assessment called the Glasgow Coma Scale.
That is an overwhelming amount of data to gather on someone who just rolled through the ambulance bay.
It is comprehensive, but it has a glaring fatal flaw when it comes to the reality of emergency medicine. These older tools, particularly the Ransom criteria, require data points that can only be fully collected and verified over the first 48 hours of admission.
Wait, if a patient is actively spiraling into a severe cascading systemic crisis, 48 hours is an eternity. You cannot wait 2 days to decide if someone needs life support.
Which is exactly why they're falling out of favor for routine emergency triage. A highly complex score that takes 2 days to calculate is completely useless if the patient crashes on a general medical ward at hour 24 because they weren't moved to the ICU. You need to make triage decisions in the first 60 minutes.
So the medical community needed something faster, something immediate that acts like a flashing dashboard light. And the current recommendation relies heavily on something called SIRS as an early predictor.
Yes. SIRS stands for Systemic Inflammatory Response Syndrome. And if we connect this to the bigger picture, SIRS is essentially the body's universal fire alarm.
Universal meaning it's not just for the pancreas.
Exactly. It is not specific to the pancreas at all. It can be triggered by massive physical trauma, a severe burn, a widespread bacterial infection, or in this case, acute chemical inflammation.
It's the body realizing that something catastrophic is happening and just throwing every physiological defense switch it has.
Exactly. It's defined by simple, immediate vital signs: an abnormally high or low body temperature, an elevated heart rate, a rapid respiratory rate, and an abnormal white blood cell count. And what is crucial about SIRS in the context of acute pancreatitis is its sensitivity.
Okay, break that down for us.
At the moment of admission, the presence of SIRS has a 100% sensitivity for predicting mortality.
Let's make sure we clarify that because medical statistics can get a bit murky.
Yeah.
A 100% sensitivity means that if a patient eventually dies from severe acute pancreatitis, they absolutely, unequivocally had the SIRS fire alarm ringing the moment they walked into the hospital. It catches every single fatal case.
It catches everyone. But the inherent trade-off in medicine is that a highly sensitive test often lacks specificity.
Meaning it catches false positives too.
A lot of them. The specificity of SIRS on admission is only 31%.
Meaning, while it catches every single person who is going to crash, the alarm is also ringing for a massive amount of people who are actually going to be totally fine. It's like a fire alarm that correctly triggers for a 5-alarm inferno, but also triggers because someone burned toast in the break room.
That is the perfect way to look at it.
Yeah.
Because pancreatitis is painful and inflammatory, many patients come in with an elevated heart rate and white blood cell count on day 1. But the critical differentiating factor is time. We look at transient SIRS versus persistent SIRS.
How long does the alarm have to ring before we know it's not just burnt toast?
48 hours.
Okay.
If the SIRS resolves, if the patient's heart rate and temperature stabilize within 2 days, their estimated mortality rate is around 8%. But if that systemic inflammation persists beyond the 48-hour mark, the mortality rate jumps to 25%.
Wow, 1 in 4.
1 in 4 patients with persistent SIRS will not survive. At that point, the specificity jumps dramatically. It becomes a highly accurate predictor of a devastating outcome.
But we're back to the exact same problem we had with the Apache-2 score, aren't we? Persistent SIRS still requires a doctor to wait 38 hours to see if it actually persists. If I'm an ER doctor, I need to know right now.
And that incredibly urgent need for an immediate, accurate bedside tool gave rise to the BISAP score.
BISAP.
Right. It stands for the Bedside Index for Severity in Acute Pancreatitis. It is a brilliant piece of clinical design because it strips away the massive 48-hour calculators and relies on 5 simple, highly predictive variables that a clinician can gather almost the minute the blood work comes back.
Here's where it gets really interesting, because looking at the 5 variables of the BISAP score shows you exactly how this disease attacks the entire body. The first variable is a blood urea nitrogen, or BUN, level over 25. What does blood urea have to do with the pancreas?
It has everything to do with the kidneys. BUN is a waste product that your kidneys constantly filter out of your blood. If your BUN level is elevated, it means your kidneys are failing to filter properly.
Now, why are the kidneys failing?
In acute pancreatitis, this happens because of the massive fluid leak we discussed earlier. The fluid leaves the blood vessels, the blood volume drops, and the kidneys are suddenly starved of the blood flow they need to function. An elevated BUN is a glaring red flag that the patient's vascular system is already collapsing.
That makes total sense. The second variable is impaired mental status, specifically a Glasgow Coma Scale score of less than 15. So any confusion, lethargy, or disorientation. Again, why is a pancreas problem affecting the brain?
Encephalopathy. The severe inflammation releases a storm of toxic cytokines into the bloodstream.
Cytokines are basically inflammatory messengers, right?
Yes, and they cross the blood-brain barrier, altering the patient's neurological function. If a patient comes in with abdominal pain and they are confused about what year it is, the systemic cascade has already reached their central nervous system.
The third variable is the presence of the SIRS fire alarm we just talked about. The fourth is age over 60, simply because older patients lack the physiological reserve to survive a massive systemic shock. And the fifth variable is pleural effusion on imaging.
A pleural effusion is an abnormal accumulation of fluid in the space between the lungs and the chest wall.
Which proves that the inflammatory fluid leak isn't just happening down in the abdomen near the pancreas. The leaky pipes have reached the chest cavity.
Exactly. So you have 5 points: BUN, mental status, SIRS, age, and pleural effusion. Each one is worth a single point. It requires no complex math. A score of 0 to 2 means the mortality risk is less than 2%. But the moment that score hits 3, 4, or 5, the mortality rate exceeds 15%.
So if a patient scores a 4, you don't send them to a regular floor, you send them straight to the ICU.
Instantly.
But I have to push back on this a little bit. If a doctor knows that the massive, complex Apache-2 score is technically more accurate in the long run, are we sacrificing patient safety just for the convenience of a quick 5-point bedside checklist?
This raises an important question about how triage actually works in the real world. You are not sacrificing safety, you are optimizing action. The primary goal in the first hour of a medical crisis is not to have a perfectly sensitive prediction of where the patient will be in 3 weeks.
Right.
The goal is simply to answer the question, does this person need life support capabilities immediately?
I see.
BISAP is highly specific. It might miss a few subtle cases that Apache-2 could catch days later, but if BISAP flags a patient as high risk in hour 1, it is almost never wrong. It gives the physician undeniable, rapid justification to escalate care to the ICU instantly.
Because getting them to the ICU is the priority.
Yes.
Yeah.
Once they are safely monitored in the ICU, you have all the time in the world to calculate the more complex long-term scores. BISAP prevents that initial fatal delay in care.
That makes perfect sense. Bedside clinical signs like BISAP and SIRS are the dashboard warning lights. They tell you there's a catastrophic problem with the engine. But eventually, a mechanic can't just stare at the dashboard. At some point, you have to open the hood and look at the actual physical damage.
And that transition from the dashboard to the engine brings us to radiological imaging, specifically the Modified CT Severity Index, or CTSI. Clinical scores tell you how the patient's physiology is reacting to the disease. The CT scan shows you the raw, structural reality of what the disease is physically doing to the anatomy.
It's an imaging score that ranges from 0 to 10 points. And the way they calculate these points is a terrifying look into how aggressive these digestive enzymes can be. The index looks at 3 distinct components. The first is grading the level of shear inflammation.
When the radiologist looks at the scan, a normal, healthy-looking pancreas gets 0 points. If the pancreas looks intrinsically swollen, or if the fat tissue immediately surrounding the pancreas looks inflamed and angry, that scores 2 points.
The enzymes are leaking out and irritating the immediate neighborhood.
Exactly. But if they see that the inflammation has progressed to actual fluid collections, or if the fat tissue has begun to undergo necrosis, meaning the fat cells are literally dying and liquefying, that bumps the score to 4 points.
Which leads right into the second component, which focuses entirely on necrosis. Fat necrosis is bad, but this component grades the necrosis of the pancreas itself.
Pancreatic necrosis occurs when the blood supply to the organ is choked off by the swelling, or when the leaked enzymes actually begin to digest the pancreatic tissue.
Digesting its own tissue.
Yes, if the organ is fully alive, it's 0 points. If up to 30% of the pancreas is dead on the scan, that is 2 points. If more than 30% of the organ has died, it is an automatic 4 points.
So you have up to 4 points for inflammation, up to 4 points for necrosis. But the third component is what truly stunned me. You can score up to 2 additional points for extra pancreatic complications.
If the CT scan reveals ascites, which is gallons of inflammatory fluid filling the main abdominal cavity, or if it shows fluid crushing the lungs, or if the inflammation is actively involving major blood vessels or the gastrointestinal tract, the radiologist adds those final 2 points.
So what does this all mean? We're taking a localized organ issue, a problem that started in a 6-inch gland behind the stomach, and we are grading its severity based on how much it has destroyed other parts of the body.
It is the ultimate proof of the systemic nature of the crisis.
It reminds me of how a structural engineer surveys a city after a massive earthquake.
Yeah.
You don't just walk to the epicenter, look at the fault line and say, yep, the ground cracked right here.
Right, you'd miss the whole picture.
You have to look at the collateral damage.
Yeah.
You have to check if the foundational supports of the surrounding high-rises, which in the body are the vascular structures, have been compromised. You have to check if the roof of the city, the lungs and pleural cavity, is caving in. The modified CTSI is the engineer's comprehensive report of the entire disaster zone.
And just like an earthquake, the initial shock is rarely the end of the story. A patient's heart rate might look stable on the monitor today, but if their CT scan shows that 40% of their pancreas is dead tissue, that structural damage is a ticking time bomb.
Because that dead tissue isn't just going to magically disappear.
Exactly. It tells the interprofessional team that this patient is at extreme risk for massive complications days or weeks down the line.
Which is the perfect entry point to understand the actual clinical course of this disease. The timeline of acute pancreatitis is brutal, and the medical community draws a very hard, distinct line in the sand between what happens to a patient in week 1 versus what happens after week 1.
It is almost like treating 2 completely different diseases depending on the calendar. The first week is defined entirely by the chemical storm. The period after the first week is defined by the structural fallout.
Let's walk through that first week, the early complications. The patient is surviving minute by minute against the systemic inflammatory response we talked about. The body is flooded with cytokines, which, like we said, are chemical messengers that tell the immune system to go into overdrive.
And this triggers multiple organ dysfunction syndrome.
Let's look at the specific organs that fail in week 1. First, the lungs.
We mentioned fluid in the lungs earlier, but the specific early complication is ARDS, acute respiratory distress syndrome. If we connect this to the mechanism of cytokines, it's important to understand that ARDS is not a lung infection. It's not pneumonia.
Right.
The cytokines circulating in the blood physically attack the delicate alveolar capillary membrane in the lungs.
The barrier that keeps the blood separate from the air we breathe.
Precisely. That barrier breaks down. Protein-rich fluid from the blood comes flooding into the air sacs. The lungs become incredibly stiff and heavy.
So they can't inflate properly.
They can't. The patient cannot absorb oxygen, resulting in profound hypoxemia. The only way to keep them alive is to sedate them, paralyze their muscles, put a breathing tube down their throat, and use a mechanical ventilator to literally force oxygen into their stiffened lungs under high pressure.
The lungs fail because of the chemical storm. Then the kidneys fail. Acute kidney injury, or AKI.
The kidneys are the most bloodthirsty organs in the body outside of the brain. They require a massive, constant flow of high-pressure blood to filter toxins.
And their blood pressure is tanking.
Right. In week 1 of severe pancreatitis, the massive fluid leak causes blood pressure to plummet. The kidneys are starved of oxygen, a state called ischemia. Furthermore, those same circulating inflammatory cytokines directly poison the microscopic filtering tubules inside the kidney.
So they just shut down.
The patient stops making urine entirely. Waste products build up to lethal levels in the blood, and the critical care team has to initiate continuous dialysis just to act as artificial kidneys.
Lungs on a ventilator, kidneys on a dialysis machine. Then the cascade hits the gastrointestinal tract. The medical term is ileus.
Ileus is a severe paralysis of the intestines. The gut relies on a coordinated muscular wave to move food and gas through the body. The intense surrounding inflammation, combined with the low blood flow, causes the intestinal muscles to simply freeze.
They just stop working.
The bowel stops moving. Gas and fluids build up massively inside the paralyzed intestines, causing the abdomen to distend and swell dramatically.
And if that wasn't terrifying enough, we reach one of the most paradoxical and lethal early complications in all of medicine: disseminated intravascular coagulation, DIC.
DIC is the ultimate physiological short circuit. It is a complete derailment of the body's blood clotting system. Normally, if you get a paper cut, your body sends platelets and clotting factors to that specific spot to build a microscopic net of fibrin, seal the cut, and stop the bleeding.
A highly localized, controlled response.
Right. But in severe acute pancreatitis, the massive release of digestive enzymes and cytokines into the bloodstream acts like a system-wide distress signal. It inappropriately triggers the clotting cascade everywhere at once.
Oh, no.
The body suddenly starts forming tens of thousands of microscopic blood clots in tiny blood vessels all over the body.
Which chokes off blood supply to the toes, the fingers, the liver.
Exactly. That is the thrombosis or clotting part of the paradox. But because the body is frantically building tens of thousands of microclots that it doesn't actually need, it completely consumes its entire reserve of platelets and clotting factors.
Right.
The supply runs dry.
Wait. If the supply runs dry, what happens if a blood vessel actually breaks?
There is nothing left to patch the hole. The patient begins to spontaneously hemorrhage. They will bleed uncontrollably from their intravenous line sites, from their gums, and internally into their organs.
So they are bleeding and clotting at the same time.
They are simultaneously clotting their organs to death while bleeding to death. It is one of the most challenging conditions an intensive care physician will ever face.
The sheer scale of the disruption is almost hard to comprehend. And there is one more early complication I want to highlight, because the mechanics of it are brutally physical. Abdominal compartment syndrome. The abdomen becomes a pressure cooker.
It is a problem of sheer physics. The abdominal cavity is an enclosed space, wrapped in tough, fibrous fascia that does not stretch easily. In week 1, you have gallons of third-spaced inflammatory fluid pooling in the cavity. You have a massive swollen pancreas. And because of the ileus we just discussed, you have paralyzed intestines blowing up like balloons with trapped gas.
All of that takes up space in a container that simply cannot expand.
So the pressure inside the abdomen rises exponentially, and that pressure has to go somewhere. It pushes upward, crushing the diaphragm so the lungs cannot inflate. It pushes backwards, squeezing the kidneys so hard that blood cannot physically enter them. But most dangerously, it compresses the inferior vena cava, the massive vein that carries all the blood from the lower half of the body back to the heart.
Wait, if you crush the vein returning blood to the heart has nothing to pump.
The patient's blood pressure instantly drops to 0.
It is a catastrophic mechanical failure. If the critical care team measures the intra-abdominal pressure and sees it reaching critical levels, there's no medication that can fix it, is there?
No. A surgeon must be called immediately to perform a rapid surgical decompression. They take a scalpel and slice the abdomen open from the chest down to the pelvis, literally leaving the patient's abdomen open, often covered with a specialized vacuum dressing, just to give the organs room to breathe and restore blood flow.
That is the reality of week 1, the chemical storm. But let's say a patient runs that gauntlet. They survive the ARDS, the dialysis, the DIC, the compartment syndrome. The inflammatory fires finally start to burn out. They enter the second phase, the late complications occurring after the first week.
If week 1 is the fire, week 2 and beyond is dealing with the charred remains of the house. It is all about structural and vascular fallout.
And the most prominent piece of structural fallout is the dead tissue we saw in the CT scan, pancreatic necrosis.
Dead tissue inside the human body is a massive liability. Initially, that necrotic tissue is sterile. It's dead, but it isn't infected. The terrifying pivot happens when that dead tissue becomes infected by bacteria.
But where do the bacteria come from if the abdomen is supposed to be a sterile environment?
They come from the paralyzed gut. The intestines are filled with trillions of bacteria, Normally, the gut lining forms a strict barrier, but because the patient is critically ill and the bowel is suffering from low blood flow, that barrier becomes incredibly permeable.
Oh, so they just slip through.
The bacteria literally migrate across the gut wall, a process called translocation, and they find a massive pool of dead, undefended pancreatic tissue. It is an all-you-can-eat buffet for bacteria.
Which instantly triggers a massive secondary sepsis.
A patient who is slowly stabilizing in week 2 will suddenly spike a 104-degree fever. Their white blood cell count will triple, their blood pressure will crash again. Infected pancreatic necrosis is highly lethal.
And you can't just fix a massive slab of infected dead tissue with an IV bag of antibiotics, right? I mean,
Yeah.
the antibiotics can't reach it because there's no blood supply to the dead tissue.
Exactly. You have to physically remove the source. This requires calling in an interventional radiologist to thread drainage tubes through the skin directly into the infected dead tissue to pull the pus out. Or, if it is too thick, a surgeon has to perform a necrosectomy, literally going into the abdomen and physically scooping out the dead, infected organ tissue.
Along with the necrosis, the body tries to wall off the disaster by forming pseudocysts.
A pseudocyst is a pocket of highly acidic pancreatic juice and inflammatory debris that the body tries to contain by building a wall of fibrous scar tissue around it. Many of these resolve quietly on their own over months.
But if they don't,
If they grow massive, sometimes the size of a melon, they can exert a mass effect. They press against the stomach so the patient vomits every time they try to eat, or they compress the bile duct. If they cause symptoms or become infected, a gastroenterologist will pass an endoscope down into the stomach, puncture a hole straight through the stomach wall into the cyst, and place a stent to drain it from the inside.
so we have infected dead tissue and massive cysts of acid. But then we get to the vascular consequences, the blood vessels surrounding the pancreas.
This brings us back to the primary weapon of the pancreas, digestive enzymes. The enzymes are designed to break down proteins and fats. If they pool outside the pancreas, they can bathe the surrounding regional arteries and veins, and they don't know the difference between a steak you ate for dinner and the wall of your splenic artery.
The enzymes literally digest the patient's own blood vessels.
They erode the arterial walls. This leads to hemorrhagic pancreatitis, which is a sudden, catastrophic internal bleed. Alternatively, the enzymatic erosion weakens the arterial wall, causing it to balloon outward into something called a pseudoaneurysm.
Like a weak spot on a tire inner tube that bulges out ready to pop.
The splenic artery runs directly along the top edge of the pancreas, making it the most common victim. If that balloon pseudoaneurysm ruptures, the patient can bleed to death internally in minutes. The only rescue is an interventional radiologist navigating a catheter through the vascular system to deploy tiny coils, plugging the bleeding artery from the inside.
And the veins aren't spared either, right?
No, the severe inflammation damages the inner lining of the veins near the pancreas, provoking massive blood clots, splenic or mesenteric venous thrombosis.
And if the veins clot.
If the mesenteric veins, which drain blood from the intestines, clot entirely, the blood has nowhere to go. It backs up, pressure builds, and the intestinal tissue is choked off. This leads to the final, most devastating late complication: bowel infarction. The intestines physically die and turn black from lack of blood flow, requiring emergent surgical amputation of the dead bowel.
It is an absolute horror story of a disease, but let's assume a patient survives this entire gauntlet. They make it out of the ICU, they go home. Their long-term prognosis and whether they will ever end up back in that nightmare scenario hinges entirely on one single question. Why did the enzymes leak in the first place?
The etiology. Acute pancreatitis rarely happens without a specific trigger, and the medical pathway diverges sharply based on what that trigger was. The two major culprits are alcohol-induced pancreatitis and biliary or gallstone pancreatitis.
And the long-term trajectories for these two causes are worlds apart. Let's look at the alcohol pathway first. The statistics are incredibly bleak. Following single acute episode of alcohol-induced pancreatitis, nearly 24% of patients will experience a recurrent attack.
Almost a quarter of them will end up right back in the hospital, and 16% will progress to a state called chronic pancreatitis.
Which is not just another acute attack. It's a permanent, irreversible state of disease. What is physically happening to the pancreas in chronic disease?
It is a process of systemic chemical erosion. If a patient continues to consume alcohol, the pancreas is subjected to continuous low-grade chemical injury. The body tries to heal the microscopic damage, but the constant insult overwhelms the healing process. Over years, the healthy, soft, functioning glandular tissue of the pancreas is slowly replaced by hard, rigid, non-functioning scar tissue. The This is called fibrosis.
And when an organ turns into scar tissue, it stops doing its job. The pancreas has two main jobs, and the patient loses both of them. First, exocrine insufficiency.
The exocrine function is producing the digestive enzymes we've been talking about. Once the pancreas scars over, it stops making them.
So they can't digest their food.
Without enzymes, the patient cannot break down or absorb the nutrients from their food, particularly dietary fats. They eat, but they starve. They suffer from profound malabsorption, rapid weight loss, and severe steatorrhea, which is chronic, foul-smelling, fatty diarrhea.
And the second job is endocrine function. The pancreas produces insulin.
Hidden inside the pancreas are the islets of Langerhans, the cells that make insulin. As the scar tissue chokes the organ, these cells are destroyed. The patient develops a very severe, highly brittle form of diabetes that is incredibly difficult to manage with external insulin.
On top of starving and becoming diabetic, they are living in agony. The nerves woven through the scarred pancreas become permanently inflamed, leading to chronic, intractable abdominal pain that often requires heavy narcotic management. And then, the ultimate tragedy. Long-standing chronic pancreatitis exponentially increases the risk of pancreatic ductal adenocarcinoma, pancreatic cancer.
It is a devastating, irreversible downward spiral. The only way to alter this prognosis is early, aggressive behavioral intervention. Achieving sustained abstinence from alcohol is the only way to stop the scarring, though even with sobriety, cofactors like smoking cigarettes, poor nutrition, and underlying genetic susceptibility can still accelerate the damage.
It requires lifelong, profound behavioral change. Now, contrast that grueling chemical erosion with the other major pathway, biliary or gallstone pancreatitis.
Biliary pancreatitis is a completely different paradigm. It generally carries a much more favorable long-term prognosis, but only if the medical team addresses it promptly and decisively.
Because the problem here isn't a systemic chemical poisoning. It is purely mechanical plumbing. Let's explain the anatomy for a second. The liver produces bile, and the gallbladder is just a small sac that stores the bile. Sometimes the cholesterol in that bile hardens into tiny rocks gallstones.
And here is where the anatomy becomes a trap. The gallbladder has a drainage pipe called the bile duct. The pancreas has its own drainage pipe for its enzymes. Right before they enter the small intestine, those two pipes merge into one single shared exit valve called the ampulla of Vater.
So if a gallstone squeezes out of the gallbladder, travels down the pipe, and gets physically wedged in that final shared exit door,
it creates a total blockage. The bile can't get out, but more importantly, the highly caustic pancreatic enzymes cannot get out. They hit the blocked door and back up into the pancreas under immense pressure. The pressure causes the tiny ducts inside the pancreas to rupture, the enzymes leak into the pancreatic tissue, and boom, acute pancreatitis.
because it's a mechanical plumbing issue, it has a mechanical fix.
Yeah.
You just take the rock out of the pipe.
Precisely. And the medical community has a highly advanced tool for this called ERCP, endoscopic retrograde cholangiopancreatography. A gastroenterologist passes a long, flexible camera down the patient's throat, through the stomach, and into the start of the intestine. They find that shared exit door, thread a microscopic wire up into the duct, grab the stuck gallstone with a tiny basket, and pull it out. The blockage is cleared instantly.
But clearing the pipe doesn't solve the fact that the gallbladder is still sitting there, full of other rocks, ready to drop another one down the pipe tomorrow.
Which is why the definitive treatment is a laparoscopic cholecystectomy. A surgeon completely removes the gallbladder, and the timing is critical. If the surgeon removes the gallbladder during that exact same hospital admission, the recurrence rate of acute pancreatitis plummets to almost zero. The factory making the rocks is gone.
But if they delay the surgery and send the patient home with their gallbladder still intact to schedule surgery for a month later,
It is a ticking time bomb. The risk of another severe, potentially fatal attack of acute pancreatitis before they get to the operating room approaches 30%. You have to remove the source immediately.
it's an incredible contrast. The mechanical, fixable nature of a gallstone versus the chronic, lifelong management of alcohol addiction. But regardless of how the patient ended up in the hospital, getting them through the ordeal we just described, from the initial fluid balance, the bedside scoring, the failing lungs, the dying tissue, to the ultimate cause, it is abundantly clear that no single doctor, no matter how brilliant, can manage this alone.
It takes an entire ecosystem. The sheer scope of the disease demands it. The source material emphasizes that early, proactive consultation with a massive array of specialists is the only way to improve survival in severe cases.
Let's look at this hospital ecosystem because it really highlights everything we've talked about. It's an intricate dance of highly specialized experts. First, gastroenterology.
The GI specialists are the endoscopists. They are the ones navigating the camera to perform the ERCP and pull the gallstone out of the duct in hour 12. Weeks later, they are the ones using ultrasound on the tip of the camera to puncture through the stomach wall and drain the massive pseudocysts.
Then you have general surgery.
The surgeons are the structural mechanics. They are taking up the gallbladder to prevent recurrence. But they are also the ultimate safety net. If the abdomen develops compartment syndrome, the surgeon is at the bedside in 5 minutes with a scalpel to open the abdomen. If the bowel dies, they are amputating the bed tissue.
Next is critical care, the intensivists.
They are the physiological conductors. When the SIRS fire alarm won't stop ringing, they take over. They manage the mechanical ventilators breathing for the patient. They manage the continuous dialysis machines. They infuse vasopressor drugs drop by drop to keep the blood pressure from crashing. They live in the minute-by-minute physiology.
And then there is nutrition. This is fascinating to me because it represents a huge shift in medical thinking. Why is a clinical dietitian consulting on an unconscious patient in the ICU?
It is arguably one of the most vital interventions. For decades, the dogma was to completely starve pancreatitis patients. The thought was, if food stimulates the pancreas to make enzymes, we should give them zero food. Feed them only through an IV so the pancreas rests.
I mean, it sounds logical.
It does, but it ignored the gut barrier. When you starve the gastrointestinal tract, the microscopic villi that line the intestines wither and atrophy, the barrier weakens, which is exactly what allows those gut bacteria to leak across and infect the dead pancreatic tissue.
Ah, the translocation we talked about.
Yes. We now know that enteral feeding, placing a feeding tube past the stomach directly into the lower intestine and dripping specialized liquid nutrition into the gut keeps the intestinal barrier healthy and robust. It prevents the bacteria from escaping. Dietitians carefully calculate and manage this highly complex feeding chemistry to literally save the patient from secondary sepsis.
We also have behavioral health and addiction medicine stepping in.
For alcohol-induced cases, this is the definitive cure. The critical care doctor saves their life today, but the addiction specialist saves their life tomorrow. Engaging behavioral health while the patient is still terrified and hospitalized significantly enhances long-term sobriety rates and prevents the slide into chronic pancreatitis.
Endocrinology is also on the list.
They manage the severe, brittle diabetes that emerges as the pancreas dies. They also manage extreme cases of hypertriglyceridemia, which is when the fat levels in the blood are so astronomically high that the blood literally looks milky, which can be a standalone cause of pancreatitis.
And finally, interventional radiology, or IR, the modern, minimally invasive miracle workers.
IR has completely transformed the mortality rate of this disease. 30 years ago, if you had a massive collection of infected dead tissue deep in your abdomen, a surgeon had to cut you wide open to clean it out. The trauma of the surgery alone killed many patients who are already weakened by the disease.
But now,
Today, an interventional radiologist can look at a live CT scan, guide a needle perfectly between the stomach, the liver, and the colon, and place a drain directly into the abscess through a tiny nick in the skin. They achieve the exact same result without the massive surgical trauma.
if you are ever advocating for a family member going through this multidisciplinary list is your ultimate checklist. A pancreas problem requires a lung expert, a kidney expert, a surgeon, a dietitian, a behavioral psychologist, and a radiologist, all operating in perfect synchronization.
And this brings us full circle back to the machine learning models we discussed at the very beginning. How does a modern, overwhelmed hospital coordinate this massive team without dropping the ball? The communication required is astronomical.
It's a logistical nightmare.
The future of this field is algorithms that not only predict fluid needs, but instantly coordinate the ecosystem. The moment the BISAP score hits a 3, the algorithm automatically pings the intensivist. The moment the CT scan identifies a gallstone, it alerts the gastroenterologist. It ensures the right expert is at the bedside at the exact right hour.
What an incredible journey we've taken today. We started by completely unlearning the historical instinct to fight a systemic fire by flooding the patient with liters of water, realizing that drowning the tissues causes way more harm than good.
We explored the terrifying art of early prediction, understanding that waiting 48 hours for a perfect score is fatal, and learning how to read the immediate dashboard warning lights of SIRS and the BISAP variables to triage patients to the ICU.
We looked under the hood with the modified CT severity index, grading a localized organ disease by the horrific collateral damage it inflicts on the surrounding vascular and respiratory structures.
We mapped the brutal 2-part timeline of complications. The week 1 chemical storm that paralyzes the gut, crashes the kidneys, and drowns the lungs, followed by the week 2 structural collapse of infected dead tissue and eroding arteries.
We split the road between the chronic, tragic chemical erosion of alcohol addiction and the acute mechanical plumbing blockage of a microscopic gallstone. And we finish by assembling an entire hospital's worth of specialists to guide a patient safely to the other side. It is a staggering amount of clinical logic.
It truly is. But before we finish, I want to leave you with one final, provocative thought. A glimpse into the very edge of where this science is heading, based on a brief mention in the research regarding immunomodulation.
Modulating the immune system itself.
Think about everything we discussed today. Draining fluids, putting patients on ventilators, performing dialysis, scooping out dead tissue, all of those are reactive. We are brilliantly managing the catastrophic aftermath of the enzymes leaking and the immune system going nuclear.
We're just managing the ruins of the house.
Precisely. But what if the future of treating acute pancreatitis isn't about managing the aftermath at all? What if, in the next decade, we develop a pharmacological switch? An immunomodulatory drug that a paramedic can inject into the patient the moment they enter the ambulance.
Oh, wow.
A drug that instantly neutralizes the leaked enzymes and chemically silences the cytokine storm before it ever starts.
And not just fight the fire, but to instantly suck the oxygen out of the room so the fire simply ceases to exist. No leaky vessels, no failing kidneys, no dying tissue.
It is the holy grail of pancreatology, and given the speed of modern biological research, the ability to instantly turn off the body's most terrifying alarm system might be a reality sooner than we think.
That is an incredible thought to end on. Thank you to our expert for translating the profound logic behind this chaotic disease. And thank you, the listener, for taking the time to truly understand the mechanics of the medical world. The reality of how our bodies fail and how medicine pulls us back from the brink is vastly more complex than a simple X-ray. But the best way to conquer that complexity without feeling overwhelmed is to keep taking these deep dives, one fascinating topic at a time. Stay curious, and we will catch you on the next deep dive.